may think that weight loss medications are only on the scale. I actually believe they are an important tool in our chronic disease prevention. Hi, I'm Amber, a registered dietitian that helps young and middle-aged adults reduce their risk of developing chronic diseases like type 2 diabetes, heart disease, fatty liver, Alzheimer's, cancer, etc. Now, if you do not have the time or money to see a registered dietitian, then this is the channel for you. Every major medical society has deemed obesity a chronic disease, not just abnormal eating behavior. They also agree because obesity is a disease all on its own, it should be treated all on its own. This is especially important because obesity can increase the risk of developing other chronic diseases. So I'm not going to argue in this video with the American Medical Association or the NIH. Instead, what I'm going to talk about is how these weight loss medications like semaglutide and tirzepatide actually work in the body to reduce our risk of chronic diseases, not just changing our body weight. This is actually my second video in a series about weight loss medications. So if you haven't watched that first video, I recommend going back. That one will explain how these medications work generally, whereas in this video, I'm going to talk about how they work to reduce some of these chronic diseases specifically. These medications are also being studied in relationship to a bunch of different chronic diseases. So yes, type 2 diabetes, which is what they were originally developed to address, but also how do these medications reduce the risk of heart disease, polycystic ovary syndrome, sleep apnea, certain types of cancers. Emerging research is telling us that there is likely some benefit to be seen on all of these different obesity-related conditions. First, let's define what overweight and obesity really mean as a medical condition. These conditions refer to excessive or abnormal fat accumulation that poses a risk to someone's health. Historically, determining if a person had overweight or obesity came down to calculating their body mass index. Their body mass index, or BMI, is simply a ratio between their height and their weight. A BMI that calculated out to 25 to 29.9 would be categorized as overweight. A BMI of 30 to 34.9 would be classified as obesity class 1. 35 to 39.9 is obesity class 2. And anything above 40 is considered obesity class 3. Sometimes I hear people referring to their BMI and their body fat percentage interchangeably, but that is not quite accurate. BMI does not specifically address body fat percentage. It's just height and weight. Body fat percentage gives us an idea of someone's body weight, what percentage is fat, and what percentage of that weight comes from lean tissue. That's muscle, bone, water, things on our body that are not specifically adipose tissue. And this is important because what we have found is there are some folks in the overweight, maybe even in the obese BMI categories, that their weight is actually made up of a higher amount of muscle. And those folks are actually more metabolically healthy traditionally than folks who have a similar BMI, but more of their body weight is adipose tissue or fat tissue instead of muscle. In fact, at the end of 2024, the American Medical Association proposed a new criteria for defining obesity, which would include, yes, calculating BMI because it is easy, accessible, and inexpensive to do. But then also for folks who have an elevated BMI calculation, digging a little bit deeper into a body fat percentage or where the adipose tissue is stored on the body, because even that can impact someone's relative risk of developing a chronic disease. For instance, if someone has more adipose tissue in their midsection, that is more dangerous when it comes to developing things like type 2 diabetes, heart disease, cancer, etc. Whereas if a person stores more of their body weight in their butt, their thighs, their extremities,
that is actually a little bit more protective from some of our chronic diseases. So currently, the prevalence of obesity in the US is about 43% in adults. That is folks who have a BMI of 30 or higher, about 43%. Now, by 2050, it is estimated that obesity prevalence among adults in the United States will be up at about 60% if nothing changes. Now, obesity class 3 specifically, that highest classification of obesity, we are seeing a range of about 4.7 to 9.4% of American adults in that highest level classification. So about 1 in 10 to 1 in 20 American adults actually falls into that obesity class 3 or a BMI over 40. In 2023, about 1 in 7 or 14% of females aged 40 to 59 were considered obese specifically. So we have some idea of how many American adults are at a height and weight that would indicate that they maybe have this extra adiposity or extra weight on their body. Now, are all of these people with a BMI over 30 at risk of developing chronic diseases? Maybe not. I recently posted a video about the health at every size movement. And in that video, I talk about how a certain number is neither inherently healthy or inherently unhealthy. It's more about the behaviors that land a person at a certain body weight. And I really encourage you to go watch that video as well. However, obesity is linked with over 200 comorbidities or co-conditions. So these are diseases that tend to develop in people who are in larger bodies and have this higher BMI. So I'm not going to go over the relationship or the data that we have on weight loss medications and all 200 of these comorbidities. First of all, we don't have that amount of research. And second of all, we would be here for the rest of the year. I am today going to focus specifically on type 2 diabetes, heart disease, and polycystic ovary syndrome, and how weight loss medications are showing improvements in the development, prevalence, and prognosis for patients with these three conditions. In 2020, about 38% of American adults had prediabetes or some level of insulin resistance. On top of that 38%, another 43% have diagnosed type 2 diabetes. By 2050, the projection is about 60% of the American adult population will have type 2 diabetes specifically. Now, insulin resistance is also seen in people at all BMI classifications, not just people in the overweight or obese BMIs. In 2024, a study was preliminarily presented at a conference that connected insulin resistance to 31 different diseases, including Parkinson's disease, gout, which is a type of arthritis, sciatica, as well as these more prevalent chronic conditions that we talk about most often. For females specifically, insulin resistance at any BMI was linked to higher risk of early death. And this study followed just under 430,000 adults for an average of 13 years. So that is a pretty high quality study, even though it is not a clinical trial. You may be thinking, why can't people just lose weight and reduce their risk of type 2 diabetes without medication, just by using food and lifestyle? The short answer is, if they could, they would have by now. Almost every patient on a weight loss medication has tried diet, exercise, and lifestyle interventions prior to getting on a weight loss medication, simply because these weight loss medications have not been available on the market for very long. And most people have tried dieting in some capacity at least once prior to being prescribed these medications. The other problem is that the amount of weight loss that is needed or recommended for folks to say, reverse type 2 diabetes is higher than what we typically see in the average lifestyle intervention. So, in a typical weight loss program, we see a sustained weight loss of about 5% of a person's original body weight. But the recommendation and what is often necessary to reverse type 2 diabetes is actually a 15%, sometimes larger, reduction in body weight from someone's starting weight. So even when a lifestyle intervention is successful, it is usually not successful to the degree that is actually needed to cure or reverse type 2 diabetes. Today's weight loss medications, however, like semaglutide and tirzepatide, they have been shown to, on average, create about 15 to 22% weight loss. There have been weight loss medications on the market for a couple of decades now. Those earlier weight loss medications, they also were not achieving this degree of weight loss. The only other therapy that has achieved this above 15% weight loss is bariatric surgery. So the fact that these weight loss medications are creating between 15 and 22% weight loss on average, that is in line with what we recommend to reverse type 2 diabetes. The research is really supporting that these medications are not just creating that 15 to 22% weight loss, but they are also addressing the type 2 diabetes. A 2022 meta-analysis being a paper that looks at several clinical trials altogether, found that semaglutide, like Ozempic, Rybelsus, Wegovy, and tirzepatide, Mounjaro, and Zepbound, they were more effective than other weight loss medications at lowering HbA1c. HbA1c is our blood glucose metric that looks at average blood glucose over the last 2 to 3 months. And that is one of our primary or standard markers of type 2 diabetes. Semaglutide and tirzepatide were also shown in this meta-analysis to lower fasting glucose more so than these other weight loss medications or placebo. Fasting glucose is another one of our typical biomarkers for diagnosing type 2 diabetes. And so we are seeing the semaglutide is a better medication, a better therapy for high blood sugar than previous medications on the market and better than placebo, certainly. Now, these weight loss medications are also showing some promise in slowing or preventing the progression from pre-diabetes to full-blown type 2 diabetes. There was a study done using tirzepatide in patients with elevated blood sugar, so pre-diabetes. And after 3 years of using the medication, only 1.3% of the medication group had progressed from pre-diabetes levels to type 2 diabetes levels, whereas 13% of the placebo group had progressed from pre-diabetes to type 2. Now, they also then removed the medication from the medication group for 17 weeks. And after that period of no medication, only 2.4% of the group that had been on the tirzepatide progressed to type 2 diabetes, where in that 17 weeks, another 13% of the placebo group progressed to type 2 diabetes. So this is showing us, even in patients who are on a weight loss medication and then maybe achieve an appropriate weight and come off of the medication, they are less likely to develop type 2 diabetes. Now, that isn't necessarily saying that they are less likely to gain the weight back after they stop the medication. We'll talk about that more in another video. But in terms of chronic disease development, being able to remain at a normal glucose level as opposed to progressing to type 2 diabetes even after taking the medication, that is a good sign for chronic disease prevention specifically. So let's talk next about these weight loss medications and heart disease. In 2020, just a hair under 10% of Americans were diagnosed with cardiovascular disease. However, cardiovascular disease is the leading cause of death worldwide, and 51% of Americans have high blood pressure. And high blood pressure is often called the silent killer because many people don't know that they have high blood pressure. High blood pressure is a really high risk factor for developing other types of chronic diseases. And because we don't know we have it, it oftentimes goes untreated. Now, obesity, especially excess adipose tissue in that midsection around our major organs, is the primary risk factor for developing cardiovascular disease. In short, being overweight puts extra stress on your heart by raising your blood pressure, raising your cholesterol, and raising your blood sugar levels. Too much fat tissue can cause inflammation and clog your arteries. Both of these things just make it harder for blood to flow to the, other parts of your body and deliver oxygen to all those tissues. And without oxygen, we are at a higher risk of heart failure, heart attack, and strokes. Type 2 diabetes and insulin resistance are also major drivers for cardiovascular disease because when we have sugar pooling in the bloodstream instead of entering the cells, it makes our circulatory system and our vascular system less flexible. We want our vascular system to be flexible and responsive to when, conditions change around us and our blood pressure goes up or down. If it's not flexible, then again, it makes it harder for the body to appropriately deliver blood and oxygen where it needs to go. I will talk a lot more about this when we get to the cardiovascular disease series on this channel. Now, just like type 2 diabetes, some improvements in health and risk can be made with smaller amounts of weight loss. However, we are still recommending for people with a risk of cardiovascular disease who have a BMI of 30 or higher that they lose around 15 to 20% of their original body weight. Again, lifestyle, diet, and exercise. If we're only achieving in that 3 to 7% body weight reduction, they may be improved, but the relative risk reduction at a 3% weight loss versus a 15% weight loss, it's just not that comparable. Diet, exercise, lifestyle alone is probably not enough to make a meaningful reduction in risk of cardiovascular disease for most of these people. A clinical trial called the SELECT trial included 17,000 adults, and it looked specifically at semaglutide usage in people who had obesity and they had an elevated risk for cardiovascular disease, but they did not have type 2 diabetes. And this study was specifically looking at, can we reduce the risk of cardiovascular disease? It wasn't really looking at weight and it wasn't really looking at blood sugar necessarily, but it was looking at, can we improve cardiovascular health in this group of people? This study found that 52% of the semaglutide group improved their BMI, as opposed to just 15% in the placebo group. 12% of the people on semaglutide actually brought their BMI down to below 25, which means not only were they no longer considered obese, they weren't even considered overweight. In the placebo group, only 1.2% achieved that reduction to a BMI under 25. The medication group also reduced their waist circumference, so looking at that adiposity in the midsection, by 7.7 centimeters. The placebo group reduced that midsection circumference by just 1.3 centimeters. Now, we know from other research that a 4 centimeter reduction in the circumference of the midsection, where that really dangerous adipose tissue lives, can provide massive benefits in the reduction of cardiovascular disease and type 2 diabetes risk. Now, again, the medication group far exceeded, almost doubled that recommended 4 centimeter circumference reduction, whereas the placebo group did not really come close to what they needed to lose to reduce their risk of cardiovascular disease. Another study found that semaglutide improved the prognosis or the course of disease for folks with heart failure that was specific to obesity-related heart failure. Now, as a person with a family history of cardiovascular disease, this is huge news to me. And as a dietitian, it seems like this medication is a really worthwhile tool for our patients that have these obesity-related conditions. As I said, obesity and insulin resistance are linked to a whole slew of chronic diseases. So these medications could really improve the lives of a lot of patients with a lot of health challenges. But the last condition I'm going to talk about in this video specifically is PCOS, or polycystic ovary syndrome. Now, this condition is a hormone condition that seems to be related to insulin resistance that leads to irregular periods, acne, abnormal facial hair or body hair growth, as well as difficulty conceiving for people with ovaries. High insulin levels seem to trigger the ovaries to make more of our typically male hormones, which can lead to these symptoms like an irregular period and acne. A study published in 2023 with patients who had both PCOS and a BMI over 30 who did not lose weight in traditional lifestyle, diet, and exercise interventions found that semaglutide medication was useful for most of their cohort. Now, they did have a small number of participants as opposed to the other studies we've talked about in this video. They had just 27 patients, but the results are still promising. And I imagine we're going to see a lot more research in this area because, to be quite honest, we do not have a lot of good treatments or a lot of good therapies for people with PCOS. Now, they found that over 80% of their participants lost at least 5% of their original body weight. Now, remember, these folks did not lose 5% of their original body weight when changing diet and exercise. So already the semaglutide has been more effective at addressing BMI and excess weight and adipose tissue than lifestyle intervention. Even those who didn't lose that 5% or more of their original body weight did see improvements in insulin resistance with the semaglutide medication, and fasting blood glucose levels normalized in 80% of this cohort. In patients who lost more than 5% of their body weight in 3 months of starting the semaglutide medication, they continued taking this medication for another 3 months. At the end of the 6-month trial, the average weight loss in that group was 25 pounds, and the average BMI of the group dropped from 34.4 to 29.4. So they dropped from nearly class 2 obesity to under class 1 into the overweight BMI. And 80% of that group actually achieved regular or normal menstruation cycles. Again, we do not have a lot of therapies or a lot of treatments, medication or otherwise, that produce these kinds of results in people with PCOS. Sometimes regular weight loss and weight management programs work for these folks, but as we saw from, the original 27 in this semaglutide cohort, it doesn't always work to just change diet and exercise in people with PCOS. So again, really promising research into some of our chronic conditions and chronic diseases that we don't have a lot of good options for. Now, as a dietitian, you are never going to catch me promoting a quick fix or a pill that can replace a healthy diet. But obesity is a complex chronic disease, and we don't tell patients with other types of diseases not to take a medication that they would seemingly benefit. So I do think that these medications have a place in our toolbox for addressing obesity and chronic. We also can't forget the social determinants of health, the environments in which we all operate that got us as Americans into the health situation that we are in. So I also don't think that prescribing medications is the only step we should be taking to address the obesity epidemic. So last big reminder, these studies have also shown these weight loss medications are most effective when they are paired with a healthy diet and with exercise. So just because you are taking a weight loss medication doesn't mean you don't need to think or worry about what you are eating. In fact, research is starting to come out looking at the typical diet of people on these weight loss medications and finding that there are some holes, there are some deficiencies in what these patients are eating. So my next video, I am going to dig into if you were on one of these medications, or if you're considering one of these weight loss medications, what nutrients seem to be missing and what nutrients or what foods you should really be focusing on or prioritizing when you don't have the same level of appetite or the same level of intake as you did prior to taking the medications. So I hope you learned something from this video, and thank you so much for being here.